Welcome to Chapter 7, Dysrhythmia Interpretation and Management. As a critical care nurse, it's very important to be able to quickly and correctly identify any changes in the patient's cardiac rhythm. Not only this, but also be able to anticipate the hemodynamic consequences of these changes and be able to find out what needs to be done to return the patient to a safe cardiac rhythm. All of this would allow us to give better care. It's going to improve patient safety and make sure that our patient would have a successful outcome. You are going to hear the word dysrhythmia or arrhythmia, and they are interchangeable, and that means any changes in deviation from normal sinus rhythm. We're going to talk a little bit about physiology of the heart because that's going to help us understand what goes on when the rhythm is generated. As you remember from your anatomy and physiology class, cardiac cycle is composed of two different activities. There is an electrical component and there is a mechanical component. So the electrical component has to occur first to be able to generate that stimulus for the mechanical or the muscular contraction to occur, and that would be your heartbeat. The electrical component has two phases: a depolarization phase and a repolarization phase. The depolarization phase is your active phase. This is when the contraction occurs. And the repolarization phase is the resting phase. Why do we need a resting phase? Because we have to give the heart time to fill appropriately and enough. During the contraction, the chamber that's contracting will not fill. So we have to make sure that we give the heart the chance to fill appropriately and quickly. We do have two mechanical responses to these two electrical activities. We have systole and diastole. So depolarization really is your systole, which is cardiac contraction, and repolarization is diastole, which is the resting phase. Again, the electrical activity has to occur before the mechanical activity. If the impulse is not generated, you will not get a contraction. And then the whole of this, which means your electrical and your mechanical contractions and activities, are basically that heartbeat. Several words that you would have to remember as part of the cardiac electrophysiology, because they are going to help you understand how the heart functions. The first word is automaticity. Think about this. If the heart does not generate an impulse automatically and would have to rely on an outside stimulus, the patient would have a lot of problems, right? Because if the brain does not send that stimulus to the heart so that it can generate an impulse, then you're not going to have a heartbeat. In order for the heart to function appropriately, each cardiac cell is able to generate an electrical impulse spontaneously by itself without the need from an outside stimulation. This is good because that means that our heart will beat. Excitability is the next word that I want you guys to think about. That is the ability of the non-stimulus generating cells, non-pacemaker cells, to respond to that stimulus that is coming and contract. So if your heart was only able to generate an impulse but not to respond to it, again, contraction wouldn't occur. Next word is conductivity. This means that each cell in the heart is able to receive and transmit the stimulus that is coming from your pacemaker cells. This also helps in propagating that signal and causing that general contraction of the cardiac muscle. And then, of course, contractility is what happens when the automaticity, excitability, and conductivity all work together to generate and propagate the signal and allow the heart muscle to contract. In all of this, we also need to give the heart a rest. This is what your refractory period is. This is basically when the heart muscle is stimulated enough not to be able to respond to another stimulus coming. This goes somewhat beyond the length of the cardiac contraction, and it also helps protect the heart from spasms. There are two refractory periods. There is absolute refractory period and relative refractory period. Absolute period is when no matter how big the signal is, the cardiac cells will not respond. So that is really when the heart is contracting. So when we look at each component of an EKG, this would be during your QRS segment. So the heart will not respond to any stimulus. The relative refractory period is the vulnerable period of the heart. This is basically when some of the cardiac cells have lost that stimulation and can generate a stimulus if the signal that's coming in is big enough. This could cause problems when we are looking at some of our ventricular rhythms, because sometimes ventricular tachycardia can occur because of signals coming in during that relative refractory period. So looking at your different portions of the EKG, the absolute starts from the beginning of your QRS and goes to the middle of the T wave. And the relative is from the middle of the T wave to right before your next cardiac cycle. And again, we do worry about that relative segment because it can cause lethal arrhythmias. There are several different ways that the heart can get stimulated. The chronotropic stimulation is basically what affects the heart rate. So you may hear a positive chronotropic stimulation or a negative chronotropic stimulation. Positive stimulation will increase heart rate. Think about some of the medications that we give. Some of our medications, like atropine, will increase heart rate. That's a positive chronotropic effect. We also do give some medications that decrease the chronotropic stimulation. Think about some of the beta blockers or calcium channel blockers that would decrease heart rate. That's a negative chronotropic effect. Digoxin has a negative chronotropic effect. Inotropic effect is any stimulation that causes a change in the contractility of the heart. Again, positive and negative effects. Again, think about some of your medications. Think about dobutamine. We're going to be talking about dobutamine when we talk about cardiac alterations. But dobutamine has a positive inotropic effect. It increases force of contraction. Digoxin also has a positive inotropic effect. It increases force of contraction. So digoxin has two different effects. A negative chronotropic effect because it decreases your heart rate, but a positive inotropic effect because it increases the force of contraction. Dromotropic effect is any stimulation that will affect the conduction time. If you think about some of the medications, again, that we give, adenosine does have a dromotropic effect because it slows the conduction time through the AV node. So keep these words in the back of your mind as you look at some of the medications and some of the treatments that we are going to give. We are going to talk a little bit more about chronotropic, inotropic, and dromotropic effects. Little bit about the innervation of the heart. The heart is innervated by both the sympathetic and the parasympathetic nervous system. Sympathetic nervous system releases epinephrine and norepinephrine. This is basically your fight or flight, if you remember. So what do we see with a sympathetic stimulation? It has both positive chronotropic, positive inotropic effect, which means increase in the heart rate, increase in the force of contraction. It increases workload of the heart, increases oxygen demand because the heart is working just that much harder. Parasympathetic stimulation, on the other hand, has the opposite effect. It brings down the heart rate, and it may also affect the force of contraction. Vagus nerve is the major contributor to the parasympathetic stimulation. So when we talk about vagal maneuvers, that means that we are doing something that's going to stimulate the vagus nerve, parasympathetic stimulation, which would decrease your heart rate. So let's talk a little bit about the conduction system of the heart. This is going to help us figure out where the signal is coming from, where is it going next, and what happens when the signal gets there. The sinoatrial or your SI node. This is in the upper posterior part of the right atrium. It's the pacemaker of the heart. It depolarizes more rapidly than any of the other cells in the cardiac system. It is the dominant pacemaker of the heart, and the rate of impulse generation from the SA node is 60 to 100 beats per minute. This is your normal heart rate. So as you can see, if your SA node is functioning appropriately, your heart rate should stay within that range of 60 to 100 beats. When it doesn't function appropriately, then that's when we have our dysrhythmias. So as the signal is generated in the SA node, it has to spread into the atria first, because remember, the atrial contraction always comes before the ventricular contraction. So it travels through the interatrial septum through some of the pathways, and it's called Bachmann's bundle, and it starts in the right atrium, travels into the left atrium, and it causes the contraction of both atria. It gets to the AV node before the atria is totally depolarized and contracted. So the signal will get to the AV node before the contraction of the atria is complete. So the signal will get to the atrioventricular or the AV node, which is located between the atria and the ventricle, hence the name atrioventricular. It does receive the signal and it slows it down, because remember, the signal gets to the AV node before the contraction of the atria is complete. So we do have to slow it down just a touch to allow the atria to completely contract. From the AV node, it will travel down into the ventricles and generate the impulse there. It does allow for a slight time delay so that atrial depolarization is complete before ventricular depolarization starts. From the AV node, the signal is transmitted to the bundle of His in order for it to go down into the ventricles so that the ventricles can contract. From the bundle of His, the signal goes down the right and the left bundle branches, get inside the ventricle, and allow the ventricles to receive the signal and contract. And then from the bundle branches and we get to the Purkinje fibers, which are inside the walls of the ventricles, and they supply a pathway to the individual ventricular cells to allow for contraction of the ventricles and ventricular depolarization. These Purkinje fibers are terminal, basically the terminal filaments. Remember, we talked about the rate of impulse generation from the SA node was 60 to 100. Now, AV node also generates by itself impulses at the rate of 20 to 40. So that if by any chance the SA node is not working, then we do still get a heartbeat, because your next pacemaker would be your AV node. If the AV node does not function well, then the Purkinje fibers generate signals at the rate of about 20. So you also always have a failsafe to allow the heart to contract. So let's take a look at the electrodes and the lead wires and the way that we put them on the patient's chest. If you work in an ICU setting, more than likely your monitor is going to have 5 lead wires attached to it. If you work in a emergency room setting, most of the time those monitors have 3 wires attached to them. The colors and the way that we put them on are going to be the same, so no matter where you work or if you do get pulled to someplace else, you should be able to manage the monitors and the lead wires effectively. In the critical care settings, we have 5 lead wires that we have to attach to the patient's chest. The way that we do this is to make sure that we attach them in the right order so that the positive electrodes and the negative electrodes are put in the correct way, so that our EKG strip is going to look the best that it can. So we are going to put them on the right shoulder, the left shoulder, the right hip, the left hip, and one to the middle of the chest to the right of the sternum. There are many things that we have to consider before putting in those sticky electrodes on the patient's chest. Is the patient's skin moist? Have they been diaphoretic? We do have to clean that up, wipe it off, make sure that the skin is nice and dry before we put in those electrodes on, because the tape is not going to stick to a moist skin. Is the patient's skin oily? If it is, then you do definitely need to clean it up before you put the electrodes on. For that, you can take an alcohol wipe, wipe down the skin where you want to put the electrode, let it air dry. That would dry off the oil and take away the oil, and you'll be able to have good contact with the electrode. If your patient has very hairy chest, we do have to take the hair off before we can put in the electrodes, because if you don't, then you're going to have artifact and it's not going to look crisp on the monitor. The best thing to do is get a hold of a clipper, clip the hair on the chest, and put the electrodes on where you have the hair clipped. If there is no electrode clippers, if you have access to a razor, you can go ahead and shave the hair off. If all of this fails, let's say you're the nurse that's in the ambulance today and you don't have any razors or clippers, taking one of those 2-inch silk tapes, take piece off, stick it on the hair, and it's kind of like waxing. You pull it right off. It is painful. Please let your patient know it is going to hurt them, but it will take the hair off of the chest so that you can actually have good skin contact with that electrode. If you put it just on the hair, the movement and the contact that is not quite effective is going to give you a lot of artifact, and you're not going to be able to see the EKG very well. When you are going to go ahead and put the electrodes on the patients, there's one thing that you want to look at before you put the electrode on. The back of that electrode where that sticky tape is, there is some gel in there, and the gel has to be moist and it needs to look fresh. That gel is what transmits the signal from the patient into the monitor. So if that gel is flaky and dry, there is not going to be good transmission of the signal, and you're not going to have a good, nice, crisp EKG on your monitor. So take the backing off of it, inspect that gel. If the gel, it looks good, go ahead and place it on the patient. If not, take another one and make sure that your electrode is nice and fresh when you put it on. The leads have colors on them. The lead wires from the monitor have colors on them, and it also tells you where that needs to go. So when you are about to put the lead wires onto those electrodes, take a look at them. The white lead will say right shoulder, so that's where it's going to go. The black lead is at the left shoulder. The brown lead will go to the one in the middle of the chest to the right of the sternum. The green lead will go to the right hip, and the red lead would go to the left hip. So here is a visual picture of where those leads are going to go and what it's going to look like. The reason we have these several leads on the patient is that we want to be able to look at the different portions of the heart. Depending on where your positive and your negative electrodes are based on where you put the lead wires, it does give us a different vision of the heart from different points of view. And depending on what's going on with your patient, whether or not they're having a heart attack or if it's CHF or something like that, then you would be able to change your leads on the monitor to be able to visualize the whole heart. One thing to remember, especially for your female patients that have larger breasts, you don't ever want to put those left leg and right leg lead wires on right under their breast, because that is not going to have good contact. Most of the time it's moist, most of the time it's oily, so you do not want to put it under there. It also can cause skin breakdown. You always want to bring it down, put it lower on the rib cage or on their abdomen. If your patient has a large round abdomen and they do a lot of belly breathing, you may have to move those left leg and right leg leads back towards their sides, or maybe even put them on their hip, because if you don't, then you may have some artifact on your monitor. When you record the EKG, you're going to see a graph paper. Basically, it's ruled paper. You will see small boxes and you will see big boxes. Each small box is 1 millimeter across, and it basically gives you a measure. So you'll be able to measure distance or time, you also can measure amplitude or the height of your waveforms. Each big box is 5 little boxes, so it's 5 millimeters around. Again, the amplitude is the upward or the downward deflection. So this is the height of your waveform. So if you're measuring a QRS or a P wave or a T wave, you will be able to count those little boxes or the big boxes and be able to figure out how big or how small your components may be. Most of the time, the lead that we monitor the patient in is in lead 2. Lead 2 has a positive deflection, which means it goes above the baseline. So if you're putting the leads on and you're monitoring in lead 2, if you don't have a positive waveform, then you may have to look at your leads and make sure you put them on correctly. It could also mean that there is some type of electrical problem that is causing this waveform to be negative. So here is the graph paper. As you can see, each big box has 5 little boxes up and 5 little boxes across. So remember that the horizontal axis is the timing. So 5 millimeters or 0.2 seconds. Each little box is 0.04 seconds. So remember that if you need to measure distances, timing, this is how you're going to do it. If you're measuring the height, it's 1 millimeter. So each big box is 5 millimeters. So it basically gives you a ability to measure. And when we look at some of the blocks or some of the differences in communication between the atrium and the ventricle, measurements will come into effect. And this is just for you kind of to remember what they will look like. Our standard leads, lead 1, 2, and 3, will always be positive. So your QRS sections, all of your components will be above the baseline. So if you put the leads on and you look up at the monitor and you're in one of these leads, then you will know that this is, if it's positive, you're good. If it's negative, you may have to troubleshoot. And if everything is okay, then there is an electrical issue that we may need to let the provider know. So the biggest thing would be to figure out, how do we know something is wrong? It's really a step-by-step systematic approach. We have to take a quick look at the whole strip. You really can't just look at one QRS, PQRST, or one cardiac cycle and be able to say, oh yeah, there is something wrong here. You really have to look at the whole strip. And also remember, there is a patient attached to that monitor, so we want to look at them too. We want to make sure that all of our components, the P, Q, R, S, and T, are there. If something is not there, what is it? And then think about what the implications of that component not being there is. Look at the P wave across the strip, make sure that they all look the same. We want to measure the PR interval, which is the distance between the P wave and the beginning of the QRS. It tells us how long it takes for the signal to go from the atria to the ventricle. Then we want to look at our QRS complex, look at our ST segment. Is it at baseline? Is it above baseline? Is it below baseline? Because remember, your ST segment will tell you if there is a cardiac issue. Look at our T waves. Is it there? Does it look normal? Is it the same across the EKG? Be able to measure the heart rate, determine whether the rhythm is regular or irregular. Look for any type of abnormality in each beat, whether there is premature beats, whether there is beats that don't look normal. We want to be able to measure and look at all of those, and then identify dysrhythmias if they are present. If you do it this way, then you should be able to, and as you get more experience, you should be able to quickly peek at a EKG strip and be able to tell what's going on with that patient. So let's look at the different components of the EKG strip. We want to make sure that all of our components are there. We have P wave, QRS complex, T wave. Then we have the different segments that we measure. The ST segment, PR interval, the QT interval, and your R to R interval. So let's talk about each component individually. Here's your P wave. This shows you the depolarization of the atria. So this is basically generated when your atria contract. You will see a slight upward deflection of your EKG off the baseline. It should have a nice rise around the top and a nice descent. And if you look on the picture that is here, you will see this is a normal looking P wave. So as soon as the descent is complete and we're back at baseline, that's the end of your P wave. It should be upright, it should be nice and smooth, and hopefully you will have a QRS to follow. However, because of many things that can happen to disrupt that nice sharp atrial depolarization, you may see differences in the P wave. If your P wave is not generated from your SA node, it also will look different if it's generated from anywhere within the atria. So if you know what the normal looks like, it will be easier to pick up the abnormal. So these are some of the abnormal looking P waves. You don't have to memorize this, you don't have to know anything much about them, where they come from and what they mean. Just know that if they don't look anything like the P wave that we just looked at, that's an abnormal P wave, and that's something that we need to make sure we let our healthcare provider know. Next thing we're going to look at is our PR interval. The PR interval is basically how long does it take for the atria from the beginning of the signal generation to the end of that contraction. And a normal PR interval for a P that is for a signal that's generated from your SA node should be no longer than 0.20. It's 0.12 to 0.20 seconds. Let's take a look. We may see a shorter PR interval. The impulse may not be generating from the SA node, or your heart rate might be too fast and is causing a shortening of your intervals. If you look at the top picture, that is a short interval, short PR interval. It's 0.010, I believe. Now, the next picture is showing a prolonged PR interval, which means that it's longer than 0.20 seconds. That means that there is a conduction delay. Something is causing a delay for that signal coming from the SA node to get into the ventricles. And this is what your atrioventricular blocks will look like. It could be caused by medication, it could be caused by some neurologic effects. Most of the time is because of a heart block. Next component we're going to look at is your QRS component. This is the depolarization of the ventricles. You will see a small Q wave, very small, usually no bigger than one small box. This is your first deflection, which would be negative. It'll go below the baseline. Then you'll have your R wave, and then you'll have your S wave. The length of time for your QRS complex is usually 0.06 to 0.10, averaging 0.08. And that's normal. However, you could also have delays in conduction, so your QRS may look wider. Usually you don't see it any smaller than 0.06. Remember that the Q wave also can tell you that the patient is actively having a cardiac event, or at some point they have had a cardiac event. If we go back to our previous, if you think about our previous picture, we said that the Q wave shouldn't be any more than one small box. If you look at this picture, this Q wave is about 5 small boxes. So that's 5 millimeters. This is what's known as a pathological Q wave. It does tell us that the patient is having a myocardial infarction. if you do have a previous EKG, it's always good to have something to compare, because if the patient had a heart attack before, sometimes those Q waves remain and the patient will live with them for the rest of their lives. But if it's something new, that tells us that the patient is actively having a myocardial infarction. So these are some of the variation of the QRS. If you remember what the normal QRS looks like, then if you see any of these, then you will know that this is not a normal QRS. Next thing we're going to look at is our ST segment. This basically tells us that the ventricles are starting to repolarize or rest. This also will tell us whether or not the patient is having an acute MI with ST elevation or ischemia with ST depression. Usually it's fairly short, duration is about 0.2 seconds or less, and it depends on the heart rate. If your heart rate is 130, then of course your ST segment is going to be shorter than if you have a heart rate of 60. Normal appearance is baseline, flat on the baseline, just like it shows on this slide. If you look at the top picture that we have here, that is ST elevation. ST depression, I'm sorry. This is ST depression, and ST depression means that the patient is having an ischemic event. That means that the myocardium is not getting enough oxygen. This could happen during chest pain. It could happen when the patient is at rest. It just tells you that there is something going on with this patient's heart that is not getting enough oxygen. The next slide down is ST elevation. ST elevation tells us the patient is having acute myocardial injury during a myocardial infarction. This is serious. This is what they call a STEMI, ST elevation MI, which we will talk about more when we talk about cardiac alterations. But a STEMI is an emergency. This is something that we need to be able to pick up very quickly, report very quickly, and start treating very quickly. Otherwise, the cardiac damage will become permanent. You also may hear the term tombstone STs. That basically means that the patient is having a very severe myocardial infarction. The reason they call it tombstone is because they kind of looks like a headstone. So the last two are very serious, very emergent. We need to do something about it right now. Next component is your T wave. The T wave is repolarization of the ventricles. Remember when we talked about refractory period, the first half of it is part of the absolute refractory period. The second half of it is part of the relative. So if a signal comes early, you may actually see a depolarization of the ventricles again. But your T wave is should look like a bigger version of the P wave if everything is normal. It should have a nice sharp rise around the tip and a nice descent onto the baseline. It should always follow an QRS, and it should always be there. However, if the patient has had a heart attack, you may sometimes see a negative T wave, which means it goes below the baseline, or you may not see a T wave. And so here are some of the T wave variation. If you look at the middle picture, middle ECG, there you really don't see the T wave. It's flat baseline. This tells you that the patient at some point probably had a cardiac event. If you look at the bottom EKG, then you will see the negative T waves. That also tells you that the patient probably is having actively having an MI or has had a recent MI. Now, if you look at the top EKG, the tall peaked T waves usually mean that there is a problem with potassium. If you have a patient that is in renal failure, you're always going to see these tall peak T waves when their potassium goes above 5, 6. So this is something that you may want to be able to pick up quickly, because what happens when the patient has too much or too little potassium, it can cause ventricular tachycardia and lethal arrhythmias. So keep these things in mind, especially with the tall peaked T waves. Next thing is your QT interval. This is kind of like the PR interval. It tells you the duration of the contraction of the ventricles. And we usually want it to be somewhere between 0.36 to 0.44 seconds. It can vary individual to individual, but it really should not be any more than 0.44, 0.45 seconds. If the QT is prolonged, the patient becomes very high risk for ventricular dysrhythmias and sudden death. A lot of the young athletes that all of a sudden have a cardiac event, when they do an EKG, they see the prolonged QT. And this could be congenital. Patient may have been born with it. They don't know anything about it until something triggers the cardiac event. A lot of the time with the kids is they start sports, football, basketball, whatever it is, and all of a sudden they have a cardiac event. It may be caused by medication. A lot of the times in your older patients, it's the medications that's causing the prolongation of the QT interval. Amiodarone, and that's a medication, is very widely used. Procainamide and quinidine, not so much, but you still may see some older patient on these medications. It also can be because of electrolyte imbalances. Hypokalemia, low potassium, hypomagnesemia, and hypocalcemia. So low potassium, low magnesium, low calcium can also cause this. Patients who have had strokes, patients who are hypothermic, all of these could cause a prolonged QT interval, which should give us a warning that a ventricular event may be happening. So here it's what it looks like. When you look at your EKG strip, if you have 3 small bars on top of that, where it says on this, it says 3 seconds and 3 seconds. If you have those 3 small bars, and you will see them printed on that EKG strip, then you have a 6-second strip. All you have to do is count. In the case of the one that we have up on this slide, your heart rate is 1, 2, 3, 4, 5, 6, about 60. Now your monitor may show 62, you may have counted 58. This is really a guesstimate, but it should be fairly close to what your monitor says and what your assessment says. There are a couple of other ways to do it, and your book goes into several different other ways to do it. You will not be asked to count the heart rate on the exam. So just make sure that you understand what it looks like and how you do it, and we'll go from there. So the next way that we will determine rate is the block rule. This is a little bit different and a little bit more difficult than the 6-second strip rule, because with that one you just count the number, multiply by 10, you're done. Here you do have to remember some numbers, and these numbers are set in stone. The way we do with the block rule is that we find a QRS that is falling right on top of that heavy line, like this one here. So this QRS falls on a heavy line. We use that as our base. Then we look at the big box. So here is the next heavy line. That number is 300. The next heavy line is 150, the next one is 100, and the next one is 75. So here we guesstimate a heart rate of 75 or 80. Again, this is a little bit more difficult to do because you do have to remember these numbers. So in this case, we are going to find a QRS that is on a heavy line. Find this one, count the number of big boxes between this one and the next QRS. So here's 1, 2, 3, 4. Divide the number 300, which is also a set number. 300 divided by 4 will give you 75 beats. The next way is to count the small boxes and divide 1500 by that number. So here's the QRS that falls on a heavy line. They counted 20 small squares or 20 small boxes. 1500 divided by 20 will give you a rate of 75. Again, the 6-second strip rule is the easiest one, but there are different ways to do so. The next thing that we are going to talk about is determining what the rhythm looks like. On your EKG strip, there should be a consistent distance between each component. So if you're looking at the P waves should all look the same and the PR interval should all be the same throughout your strip. The distance between your QRSs also should be the same. This is a regular rhythm. This means that the rhythm has been generated from the SA node and we're good, patient's good, we're happy. If it's not, if your intervals are smaller, longer, waveforms don't look the same, that is an irregular rhythm, which means that the impulse is generated somewhere outside of the SA node. It also will tell you, is it an atrial problem or maybe a ventricular problem? So normal sinus rhythm is our gold standard. This is where we want all of our patients to be. And before you start looking for dysrhythmias, you have to know what this looks like so that you know what is not normal. Normal sinus rhythm basically starts an impulse in the SA node to AV node to the bundle branches to the Purkinje fibers. So this is a normal pathway for our impulse. So everything should look normal on that. You should have a P, a QRS, a T. Every cycle should look like that, and it should be the same throughout your strip. This is what it looks like. And remember, some of these rhythm strips that we have on this slide may not look the same as you would see on a patient because, again, patients will move around and it's a little bit more dynamic than what we have here. But if you look here, if you do look on this strip, here is your P wave, and this P wave looks the same as this one, and throughout your strip. If you look at your PR interval, the PR intervals look absolutely the same throughout. Your rate should be somewhere between 60 and 100 beat. You should have a normal R to R intervals, and everything should be identical to each other. This is your normal sinus rhythm. You walk into your patient's room, you look at the monitor, this is what you see. We are happy because with the normal sinus rhythm, patient is hemodynamically stable. They have a good blood pressure, they're oxygenating well, their color looks good, things are good. What is a dysrhythmia? Dysrhythmia really is a deviation from normal sinus rhythm. It can be different. It can come from different places. It may be because of impulse formation, it may be single, it may be continuous, it might be lethal, it may be benign. So there's a lot of different things going on with the dysrhythmias. For a dysrhythmia to be clinically significant, it has to have some hemodynamic consequences, like a drop in the blood pressure, like decrease in oxygenation, like causing pain or discomfort for the patient. So all of that has to be taken into consideration when we're looking at a patient with a dysrhythmia. And it also depends on where that dysrhythmia is coming from. Usually your ventricular dysrhythmias are a lot more significant than your atrial dysrhythmias. So a lot of things goes into figuring out what's happening with the patient. You always have to look at your patient's history. You always have to look at their symptoms. You always have to do a good cardiovascular exam. All of that will give you a whole picture as opposed to just wanting to treat that monitor. Remember, patient is attached to that, so we do have to make sure we take that into consideration. So what do we want to accomplish by treating dysrhythmias? We want to make sure that we go back to normal sinus node function. We want to make sure that the heart rate goes back to patient's baseline, that the atria and the ventricles are working together again, and we go back to normal sinus rhythm. Hopefully all of that is accomplished and we have the patient go back to normal. Sometimes we can and sometimes we can't. And then if we can't do this, then we have to make sure that we do treatments continuously so that the patient does not have hemodynamic consequences. They are generally classified according to where they come from, their site of origin. Sinus node can have dysrhythmias, then you have atrial dysrhythmias, dysrhythmias of the atrioventricular junction or ventricular dysrhythmias. And as we go down this list, the seriousness of the dysrhythmia increases. Your sinus node dysrhythmias are usually your most benign. We do have to treat them, we do have to figure out what's happening with the patient, but usually they are the least hemodynamically significant dysrhythmias. As we go down the list, things get worse, and your ventricular dysrhythmias usually are your worst dysrhythmias. Let's talk about dysrhythmias of the SA node. They're, again, some of the most benign dysrhythmias. They could potentially cause harm if we let them go for a long period of time. But for the most part, they are pretty benign. We are able to treat them very quickly, and usually the patient responds well to treatment. These dysrhythmias are sinus bradycardia, sinus tachycardia, sinus arrhythmia, and sinus arrest. Looking at the sinus bradycardia, this rhythm is regular. You have P waves everywhere. So here's a P wave, here's a P wave, here's a P wave. If you look throughout the strip, all the P waves are present and they look the same. Your QRSs are all present and look the same. Your intervals look the same. But the only thing that's different between this and a normal sinus rhythm is that the rate is less than 60. We have to figure out what the problem is with that patient that is causing their heart rate to be less than 60. Observe the patient, get a set of vital signs, and speak with the patient. See what's going on with them. This sometimes is a normal variation. If you have an athlete, maybe a triathlete, maybe a runner, a swimmer, sometimes they do live at a rate of 45, 50. They have really good blood pressure, their color is good, their body temperature is normal. That's normal. We don't want to treat that. That patient lives there, they're happy, we're good. If the patient is having symptoms, like their blood pressure has dropped, they're having chest pain, they may be having altered level of consciousness, at that point we have to figure out what's going on with that patient. Usually your drug of choice is atropine. It's your first resort. 0.5 milligrams to 1 milligrams, and you can repeat up to 3 milligrams per kilogram. If that doesn't work, then we have to move up to temporary pacemaker. If the pacemaker is still not very effective, you can also put them on a dopamine drip, norepinephrine drip, things that would cause that heart rate to come up. Now, another reason why a patient could be in sinus bradycardia is if they're asleep. If the patient sleep, their heart rate will drop. Please don't wake them up. That's fine. When they wake up, their heart rate should go back up to their normal level. But again, atropine is your drug of choice, 0.5 milligrams to 1 milligram. If atropine doesn't work, temporary pacemaker, and epinephrine, norepinephrine, or a dopamine drip. Next one is sinus tachycardia. Again, if you look here, you see your P waves. They're all there. You see your QRSs. Your rate is greater than 100. Here, your rate is probably about 120. Everything is normal. However, your intervals are shorter because your heart rate is a lot higher. There's always a reason for sinus tachycardia. Pain could increase patient's heart rate. Anxiety could increase patient's heart rate. Dehydration and fever. We have to treat the underlying cause to bring the heart rate down back to a normal sinus rhythm. So we might want to give them IV fluids, anti-anxiety, pain medication, antipyretics, things to make sure that we get the underlying cause taken care of. As soon as that's done, patient's heart rate should start coming back to their normal. Next rhythm that we're going to look at is sinus arrhythmia. The only difference between sinus arrhythmia and normal sinus rhythm is that sinus arrhythmia is irregular. This is because of a respiratory variation. As the patient inhales, the heart rate increases. As they exhale, the heart rate decreases. Everything else is normal. Everything else is the same as a normal sinus rhythm. It's just slightly irregular. So the next rhythm that we're going to look at is sinus pause or sinus arrest. If you look at this strip, the beats that you have, this one here, and this one here, they all look the same. They are generated by the sinus node. The pathways is normal. All of your intervals and components are there and they're normal. However, what's happening here is that after this beat, the sinus node is not generating any impulse. So there is no contraction anywhere. This is a problem. This usually happens due to oxygenation issues, ischemia to the sinus node itself, ischemia to the heart, so during a cardiac event. We have to treat the underlying cause, figure out what is happening to the patient that is causing that sinus node not to work right. Most of the time, your intervention of choice is putting in a temporary pacemaker. Sometimes if we can't figure out or we can't treat the underlying cause, we may have to put in a permanent pacemaker. But there is really nothing that we can give to this patient to start the heart rate. So temporary or permanent pacemaker is the treatment of choice here. The next group of dysrhythmias we're going to look at are atrial dysrhythmias. These are dysrhythmias that are coming from somewhere in the atria. So you will see premature atrial contractions, or PACs, supraventricular tachycardia, or SVT, paroxysmal atrial tachycardia. You will also hear paroxysmal supraventricular tachycardia, atrial flutter, and atrial fibrillation. Let's look at premature atrial contractions, or PACs. Look at the strip on this page. So here is your first beat. Here's your second beat. They look the same. They look the same throughout. Now, if you look at this one here, this is coming in the second half of the T wave. Remember when we talked about refractory periods? We said that the relative refractory period starts in the second half of the T wave, where a strong enough stimulation can cause contraction. This is basically what that is. So here's your T wave from this cardiac cycle. Right in the back end of the T wave, this is your premature beat. It's an early beat. It's not the interval between this R and this QRS, and this QRS is not the same as this one or as this one. So this is an early beat. And if you look at the P wave, it doesn't look anything like the other P waves. You do have a slight pause because the heart is just trying to recover from that extra contraction. So here you see, here is one PAC here, here's another PAC here. So the thing to remember is that these are early beats. In and of itself, they are pretty benign. Sometimes they happen, you see them in females, sometimes they just happen because of electrolyte imbalances. We just have to figure out what's going on. The patient may live with them throughout their life and not have any problems with them. So we just observe these patients. There is really no treatment for them. If they are new, we just want to make sure that we let our provider know. The next strip we're going to look at is supraventricular tachycardia, or SVT. If you look at this strip here, you're going to notice a difference between this and sinus tachycardia. If you remember sinus tachycardia, you were able to see the P wave separately, the T wave separately, and then your QRS. Here, you're not able to see the separate waveforms for your P wave and the T wave, but this is what you're going to see because this is really your P wave and T wave on top of each other. Because the heart rate is so high, between 160 and 240, you really don't have a lot of refractory period and resting period in your strip, so you will not see those separately. Treatment depends on hemodynamic stability of the patient. If the patient is stable, all they're telling you is, really, my heart is coming out of my chest, it's really beating fast. Their blood pressure is normal, their oxygenation is normal, their color is normal, they don't have any changes in their level of consciousness, we can start with vagal maneuvers, asking them to take a deep breath and cough, asking them to bear down, maybe doing a small carotid massage. Sometimes that will work and break the cycle of this and take them back to their underlying rhythm. If the patient is not hemodynamically stable, you see a trending of blood pressure going down, you see a trending of oxygenation going down. They're telling you, oh, I'm starting to get a little dizzy. My chest is starting to hurt. At that point, you really don't want to do vagal maneuvers. You want to do something to quickly take them out of this rhythm. You would start with adenosine. Remember that adenosine has a very, very short half-life. You do have to give adenosine very close to the hub of the IV, and you want to flush the adenosine with 20 milliliters of normal saline in a syringe. Your starting dose is 6 milligrams. You can follow it with 2 doses of 12 milligrams. If adenosine does not work, you move on to cardioversion. Now, if your patient is really unstable, their blood pressure is 60, their oxygen is dropping into the 70s, you really don't want to give them med first. You want to do the first thing that you can to get them out, and that would be cardioversion. So again, remember that the treatment here will depend on the stability of your patient. The more unstable, the more invasive things that you want to do to them. The next rhythm that we're going to look at is paroxysmal supraventricular tachycardia, or PSVT. This is basically if your patient is having a normal rhythm and all of a sudden you see a period of SVT. It starts abruptly, it stops abruptly. Usually you don't do anything for it to stop. It stops on its own, and it may come and go. So the patient may have periods of SVT. What you would do for this is basically the same thing as you would do for SVT. You treat the underlying cause and treat symptomatic treatment based on how unstable the patient becomes during the times when they are in SVT. The next rhythm we're going to look at is atrial flutter. Atrial flutter has a distinctive look to it, and you should be able to recognize it most every time that you see it on a screen. The reason for the distinctive look is the lack of an actual P wave. What you see on the screen is these sawtooth flutter waves, which basically tells you that the contraction of the atria is really not a contraction, but just a movement. The rate is usually normal within 75 to 150. Sometimes it does go up above 180, and that's when your patients become very unstable. The rhythm should be regular. Sometimes you do see a little bit of irregularity to it, but for the most part it is regular. The only thing that you can measure as far as intervals is your QRS interval, because there is no P wave or T wave for you to take a look at. For the treatment of atrial flutter, if it is new onset and the patient is fairly stable with it, we still can kind of watch them. We definitely do need to anticoagulate them. If their rate is above 100, then we want to give them medication to bring the rate down, something like an amiodarone, beta blockers, DIG, calcium channel blockers, something that will bring that heart rate down. If it's a new onset that has a rate of greater than 180 and your patient is unstable, meaning the patient is dizzy, they have chest pain, their blood pressure is low, they can't oxygenate well, we have to go with cardioversion because obviously the patient is not tolerating this rhythm. Sometimes patients can become unstable with rates less than 180. If it's a new onset and your patient is unstable, cardioversion would be one we want to do because it will automatically bring them hopefully out of atrial flutter. If your rhythm is long-standing, let's say the patient has been in atrial flutter for a year, 6 months, or if we don't know how long the patient has been in atrial flutter, we definitely need to anticoagulate these patients. Even the patients that have new onset atrial flutter, we have to anticoagulate because remember, if we don't contract, then we have pooling of the blood. And with the pooling of the blood, we have potential for clot formation. And if we don't do anything about that, those clots can travel to the brain, causing a stroke, to the lungs, causing PEs, any type of catastrophic event that clots will cause. So if your rhythm is long-standing or we don't know how long the patient has been in it, then we have to anticoagulate them. Usually in the hospital setting, we start them on heparin, and then before they go home, we switch them to Coumadin. If we do need to cardiovert them, the patient has to be anticoagulated for at least 4 to 6 weeks before we can safely go ahead and cardiovert them. The next rhythm is atrial fibrillation. There is a difference between atrial fibrillation and atrial flutter because atrial fibrillation is not regular. Nothing is measurable. You don't even have those sawtooth waves. It looks kind of like a squiggly baseline, and that basically is what the atria is doing. It's really moving, but it's not fluttering, it's not contracting. It's just a very irregular, erratic movement. These patients are even at higher risk for formation of clot because we really are not moving blood out of the atria properly. The treatment is the same as atrial flutter. If they're unstable, you do cardioversion. If they're fairly stable and their heart rate is less than 180, then we can go ahead and medically treat them. Anticoagulation is the same. You want to leave them anticoagulated for life. Next group of rhythms that we are going to look at are your atrioventricular blocks. This is a disruption or maybe a delay in the conduction of impulses between the atria and the ventricle. You may have a partial block, you may have a total block, or it just might be a delay. And the block can occur at anywhere, at the AV node, bundle of His, or any of the bundle branches. We have three categories. We have first degree AV block, we have second degree AV block, and the second degree is also divided into two types. Type 1 is also called Winky-Bach or Mobitz 1. Type 2 is also called Mobitz 2. And then third degree AV block, which is a complete blocking of the signal traveling down into the ventricle. So let's take a look at the pictures. Here is your first degree AV block. At first glance, it looks like normal sinus rhythm. The only thing that's different is the PR interval is a lot longer than 0.20. Here, if you measure this PR interval here, is 0.32, which tells you that there is a delay in the conduction of the signal between the atria and the ventricle. Think of it as a communication delay. Something is causing a delay in the communication between the atria and the ventricle. It may be temporary. It happens because of ischemia to the heart, or it may actually progress to more serious things. Next rhythm we're going to look at is second degree AV block type 1 or Winky-Bach. With Winky-Bach, what you're going to notice is that you are going to have some normal looking beats. This is still generated from the SI node. However, our communication problem, our block, is getting worse. So what you're going to see here is you're going to see a normal PR interval here. Your second beat has a longer PR interval. The third beat has a longer PR interval. And then you have a P wave that does not have a QRS after it. So that means that the signal did not go down into the ventricle. Then the next one, again, you have normal, long, longer, and then you drop one. We are going to start looking for underlying causes a lot quicker with this because this can go forward to second degree type 2 and third degree heart block very quickly. This is also due to ischemia, so we do have to figure out what's going on, give the patient oxygen, and try and fix the ischemia as soon as we can. Your next group is second degree AV block types 2 or Mobitz 2. Here, our communication is a lot longer. So here's a normal beat, normal PR interval, normal PR interval. However, we have more P waves with no QRS after it, so more blocked signals. Here's another one. Here's normal, and these are all normal. Your ventricular rate is going to be a lot slower. So with this, you're going to see a lot more hemodynamic instability. You're going to see blood pressure drop. You're going to see changes in the level of consciousness. You're also going to see patient feels dizzy. They feel nauseous. They're pale, diaphoretic. They're going to have chest pain. Again, because we are not having signal going down. Is your third degree AV block or complete heart block. Your heart rate will be somewhere around 20 to 40 because none of the signals generated in the SA node are traveling down into the ventricle. Even though here you look like you have a P wave right next to the QRS, this P wave is not generating this QRS because if it was, it would be upright, it would be narrow, it look like a normal looking QRS. So what you're going to look for is multiple P waves that look like they're marching because you count the P to P interval. Here's 2, here's another one in here, here's one here, here's one here. These all have the same intervals because they are coming from your SA node. and then you're going to have this kind of big, wide, bizarre looking QRSs because these are generated by the Purkinje fibers inside the ventricles. The only thing that we can do for this patient is a temporary pacemaker. These patients are going to be hemodynamically unstable. They're going to have low blood pressure, they're going to be dizzy, they may actually have syncopal episodes, they're going to look very, very sick. These patients are more than likely in the middle of a heart attack, so we do have to treat that as soon as we can. But a pacemaker is your intervention of choice because there is no medication that we can give that will cause the synchrony of the atria and the ventricles. And synchrony means working together. I had a professor who taught us how to read the blocks, and he kind of made it sound like communication problem between a couple. Think about first degree AV block. The person is coming home for dinner. It's coming late, but he is coming home. Second degree type 1 come home on time, they come home later, and then there is that P wave without a QRS, the person is not coming home for dinner. Second degree type 2, they have a communication, persons come home for dinner a couple of times on time, then they don't come home at all, and then they come home again, they don't come home at all. And third degree, we're getting a divorce here because the atria is doing its own thing, the ventricle is doing its own thing, and nobody's talking to anybody else. So think of it as a communication block. There's also a AV block poem. If you Google that, it'll give you a poem about how to distinguish the blocks. However, it makes it easier for you, just kind of go with that. But remember that with third degree AV block, there is nothing you can do other than a temporary pacemaker. Next group of dysrhythmias we're going to look at are the ventricular dysrhythmias. These are really called your most serious dysrhythmias. These are your lethal dysrhythmias. The most benign of all of them is the premature ventricular contractions. You're going to have ventricular tachycardia, VT or VTAC, ventricular fibrillation, and ventricular asystole or standstill. So let's look at premature contractions. Like the premature atrial contractions, these are early beats. These are also coming on that relative refractory period. So if you look on the top strip, these are called unifocal. If you look at this premature beat and this premature beat, they look the same. They're coming from the same area, the same focus. So this is the one that we worry about, not as much as the other ones. Most of the time your PVCs are due to changes in your potassium and electrolyte levels. It also can be because of hypoxia. So we do have to make sure that the patient is oxygenating well, and we need to make sure that we check their potassium and magnesium levels. The next strip, you'll see it says multifocal. So if you look at this premature beat here and this premature beat here, they don't look the same. They're coming from two different areas of the ventricle. This is a bit more serious than the unifocal because now your ventricle is more irritable. As opposed to having one area that's generating extra beats, now we have multiple areas that are generating extra beats. The next one on this side, on the left side of the screen, is what we call a couplet. We have two PVCs together. This is also more serious than your multifocal and unifocal because that area that is generating these PVCs is firing quickly. So it's firing multiple times as opposed to like the unifocals, when you have one here, you have several good beats and then you have another one. They are coming more frequently together, which could lead to a VTAC or ventricular fibrillation. The next one on the right side of your screen is ventricular bigeminy, which means that every other beat is a PVC. So all of these are pretty serious because we want to make sure that we treat them quickly so that they don't actually progress to VTAC or VFib. So here is VTAC. This is your fun rate. This is what you're going to look up at the monitor and you're going to say to yourself, oh no, something bad is happening. And more than likely something bad is going to be happening soon. The patient's rate is somewhere around 220, 240. The big thing with ventricular tachycardia is you do not call a code before you look at that patient. Sometimes patients have a pulse with this, sometimes they're awake and alert with this, so you really truly do not want to call a code before you look at your patient. So if you do see this on the monitor, you walk into your patient's room, you assess the patient first. Always assess the patient first. If you need to call a code at that point, you call a code and start CPR. It might be a short run, so you may have 6 or 8 beats together, or it may be continuous. It is life-threatening. Treatment differs between pulseless and with pulse. If your patient has a pulse and their blood pressure is still okay, you can do vagal maneuvers, have them cough, bear down. More than likely, they're not going to be stable with this rhythm, so you would have to cardiovert the patient. Cardioversion would take the patient out of this as quickly as possible, and then you want to put them on some antiarrhythmics like amiodarone, because we don't want them to go back into this. If the patient is pulseless, we call a code, we start CPR, and we go through the protocol for ventricular tachycardia, which we will talk a little bit more when we talk about codes and rapid response team. There are different types of ventricular tachycardia. The one that we just saw in the previous slide, that is the one that you're going to see most often. What you have on this slide is what's called torsades de pointe, which means twisting around a point. They don't look anything like the one that you saw before. The one that you saw before is uniform. They all look the same. Here you have smaller beats, you have taller beats. In here it kind of looks like cyclic. Here you have some upright, some smaller one, then you have some negative deflection. So it twists, it turns. The cause for this is low magnesium level. So a lot of the times if you're doing a code and nothing is happening and you're giving the medications and you're defibrillating but nothing is happening, more than likely your lab results that are going to come back are going to show a low magnesium level. At that point you can go ahead and give magnesium, and that usually will help bring the patient back out of ventricular tachycardia into a normal rhythm. The next group is ventricular fibrillation, or VFib. This is what happens if VTAC goes long. Sometimes we don't have any control over that. We could be doing our protocol and going through the ACLS protocol to try and fix VTAC, but the patient's cardiac function deteriorates even more. Here what you're going to see is really it's kind of like a squiggly line. There is no rate, you can't determine anything, your monitor will show a 0. There really isn't anything that you can measure. This patient will always be pulseless. You will always, more than likely, always see VTAC first and then VFib. But if you walk in a room and the patient is not on a monitor, you put them on a monitor, you may see this if the patient has been in VTAC, but if it's been a while for them being down. With this one, defibrillation first, CPR, and then medications based on the protocol. More than likely, the outcome for this rhythm is going to be negative. However, there has been times when patients have come back. The next rhythm is asystole, and that is basically your flatline. Now, one thing to remember, if you see this on the monitor, what are you going to do first? You're going to go into the room and assess your patient. Sometimes this is the rhythm of your bed. Patient took off their lead and it's now sitting on the bed. If you are working in a CCU, patients are sometimes allowed to get out of bed to go to the bathroom. And a lot of times they don't call you to let you know that they're doing that. So all you do is you hear the monitor beep, you look up, and that's what it is. So assess your patient. If you walk into a room, patient's sitting in a chair, they're doing well, they're looking at you, more than likely they're not in asystole. So check them out, troubleshoot, put the lead back on, you're good to go. If the patient is unresponsive, they have no pulse, they're not breathing, then yes, definitely asystole, and you go ahead and start CPR. It's only CPR and epinephrine for asystole. There is nothing else that you can do. More than likely, outcome is going to be negative here. The next thing we're going to look at is artifact. Artifact is when something is happening to those leads on the patient and it's causing a disturbance in what you see on the screen. Most of the time it's something benign. It's maybe the patient moving, maybe they're shivering, maybe they're just moving their leads around. And there's really nothing wrong with that. You just have to troubleshoot it. If you look at the top strip, this is when the patient is moving. They're moving around, they're turning side to side, and something in those leads are moving. It does look like ventricular tachycardia. It is not. What you want to do is walk into the room, take a look at the patient, see what's happening, and then troubleshoot that. Sometimes they're shivering, and the next strip is what happens when it's shivering. It kind of looks like there's a lot of QRSs and things like that. It's just interference. And we have to fix whatever the underlying cause of that shivering may be. Put some blankets on them, make sure we give them some medication, see what's happening with that patient. The bottom strip is electrical interference. It's called a 60 cycle interference, and this is because of something that is not grounded in the room. Most of the time it's an engineering problem, and they have to come in and take a look and make sure that everything is grounded, or if there is something that's malfunctioning, they take it out and bring you a new equipment. But these all have to be troubleshooted because we want to have a good crisp EKG on the screen so that we can see what's happening with that patient. The next group of rhythms we're going to look at are pacemaker rhythms. Pacemakers can be either temporary, which means we can put them in at the bedside, or permanent, which means they have to be put in under surgical conditions. Pacemakers can pace the different chambers of the heart. They can pace the atria, they can pace the ventricles, or they can pace both chambers. The first strip that you are looking at is atrial pacemaker strip. Atrial pacemakers are always permanent. So if you ever see this on your monitor, you will know that your patient has a permanent pacemaker. One thing to remember with all pacemaker rhythms is that you are going to see the signal that's generated from the pacemaker as an upright spike, like this one right here. So we'll see one right before the P wave, which means that this P wave is generated from the signal that's coming from the pacemaker. Everything else in here looks fairly normal. Your QRSs and your T waves look normal. The only extra thing that you see is pacemaker spikes right before your P wave, which tells you that this is an atrial pacemaker. The second strip that you are going to see is the ventricular pacemaker. Same thing here. You see these spikes that go up before every QRS, and all of your QRSs are going to be wide and bizarre looking. They kind of look like PVCs. However, just remember that the reason that this QRS looks like this is that we are stimulating the ventricular fibers. So that's why these beats look different. Ventricular pacemakers can be either permanent or temporary. So if we ever have to put in a temporary pacemaker, you will see this type of rhythm. The last strip that you look at is an atrioventricular pacemaker rhythm, which means that both the chambers are being paced simultaneously. This is always going to be a permanent pacemaker. You also will hear the term AV sequential pacemaker, which means that the pacer is pacing both chambers. And here you see two pacemaker spikes because we are pacing both the atria and the ventricles. Like any other normal mechanical thing, you are going to see some pacemaker problems. So let's take a look at some of the pacemaker problems that you will see. If you have a patient that has a permanent pacemaker, if you see any of these problems, you will have to always call your healthcare provider because we don't have access to the programming and the settings of that permanent pacemaker to do any type of troubleshooting or any type of fixing. So the healthcare provider will have to come in and troubleshoot and fix the problem. If your patient has a temporary pacemaker in place, though, you do have access to the pulse generator or the pacemaker box, and you are able to change settings, change the box itself, change its battery to hopefully change the problem and fix the problem and go on. So let's take a look at the first strip. The first strip is called failure to pace. If you look at this strip, we have a couple of good pacemaker generated beats. But between the two of them here, we don't have anything happening. This is usually because of some type of electrical issue with the pacemaker pulse generator or the pacemaker box. Biggest culprit is low battery. So as long as you change the battery in your pacemaker box, we should be good. It should start working again, and hopefully we won't have any more problems. Sometimes even if we change the battery, you still are going to see the failure to pace, and that means that something is wrong with that actual box or pulse generator, and so you do have to change that, and hopefully that would change the problem, fix it, and we can go on. If you've done everything that you can and you're still having failure to pace, that would be the time to call your healthcare provider so that they can come in and do some more in-depth troubleshooting so that we can fix the problem. The second strip is called failure to sense, and this really is that the pacemaker box is not seeing the patient's heart rhythm, because we are setting a heart rate and we are setting sensitivity. All of those are already set on your pacemaker box. So something is happening, either maybe the patient's heart rate is increasing, or something is happening and the pacemaker is really not detecting the patient's underlying rhythm. So if you look on here, you have a couple of good pacemaker generated beats. Your next pacemaker impulse comes right on top of your T wave here, which is a bad thing, because if you remember when we first talked about relative refractory period, we said that the second half of the T wave is where, if there is a strong enough signal, it can generate a beat. So if this impulse here actually does work and generates a beat, you are going to have an early beat. It can also cause ventricular dysrhythmias, which makes your life a lot more difficult, because now you would have to fix ventricular tachycardia. So with this type of problem, what we have to do with our temporary pacemaker is change the sensitivity setting. You will have an order from your healthcare provider that will give you guidelines as where the numbers should be. So you can go ahead and, based on what you have, based on your ranges, change your sensitivity up until where you actually see the pacemaker functioning appropriately. If you've done all of that and it's still not working, obviously you're going to call your healthcare provider, let them know what's happening so that they can come back in and do some troubleshooting and figuring out what's going on with the patient. The last strip is called failure to capture, and this is a mechanical issue. This means that your pacemaker pulse generator is supplying the signal, however, something is happening and it's not causing the heart to contract. A lot of the time is because the lead is not touching the wall of the ventricle. So if your lead is not touching a wall, no matter how much signal you generate, it's not going to cause the contraction. So sometimes it moves and touches the wall, like in this strip you see a couple of pacemaker signals but nothing behind it, and then you also have a couple of good pacemaker generated beats. So at times it moves and it captures and causes the contraction, and at times it does not. Sometimes it is because there is a either a kink or a break in the pacemaker lead itself. So that needs to be changed. That pacemaker lead needs to be changed. Or at times, if it's a patient that has had a heart attack and the tip of the pacemaker lead is touching the area of the myocardial damage does not propagate the signal. It does not transmit the signal, so the lead may have to be manipulated. We don't manipulate those leads. We don't do anything with them. With this type of problem, you would have to call your healthcare provider so that they can come in, either manipulate the lead, hopefully get it to touch where it can cause the heart to contract, or change the lead to a new lead so that if there is a break or a kink in it, we have that fixed. So this brings us to the end of chapter 7.